I really look forward to this presentation. I think what I'm going to do is just go ahead and present. I have a few, like 3 minutes, and then I'm going to turn it over to you. But I have just some background
Sure,
I do every time, so I'll go ahead and get my
that would
stuff
be
out.
amazing. Yep.
Get my stuff out of the way, and then I'll turn it over to you. So thank you all so much, and I'm sure people will start trickling in or continue to trickle in, but this first few minutes is not the meat of the presentation. But I thank you all for coming today, and I really look forward to this presentation. And we'll see how it goes. And I turned off the waiting room, so people are just going to keep coming in. But thanks so much for everyone's participation again. And, if you have any ideas, just please let me know. I'd like to pay tribute to Pope Francis. I was actually looking at, he's written a lot on artificial intelligence. And anyway, he has this publication called, I guess, Old and New. And so, anyway, I just thought that was interesting. And he has some ideas on AI that I thought were interesting about, for example, this quote was, you know, uh, it's a product of humans and not necessarily its own entity, I guess is what he's trying to say.
Mhm.
But anyway, yeah, that I thought that was interesting. So yeah, we're gonna have a great presentation today, but in 2 weeks it'll be also awesome. We're gonna have a presentation on remote digital pathology practice from Dr. Zelko Jovancek, and so that should be great. In 4 weeks, we're going to continue and I know this has taken a long time, but basically our planning of what to do next for our working group and sort of the work products that I actually love this is my favorite part, the presentations that we have every few weeks, but actually every couple weeks, but we do want to have some products, and eventually we would definitely want to help contribute to image banks and challenges and trials as we have been, and also maybe even Banff algorithms. So we'll continue to do those things. And so in 4 weeks, we'll continue our planning on the surveys we've done and also maybe a Delphi analysis. And then in 6 weeks, we're going to hear from, he's going to kick off the summer, I guess. It'll almost be summer then, Kim Soles on AI optimism in nephrology. And that's sort of based on his debate that he had with Dr. Agnes Fogo, which is available on, or basically sort of a recap of that is available on YouTube. And so again, thanks for your participation, and let me know if you have any ideas, especially speakers. If you have any ideas for speakers, just let me know because I need to start planning, or maybe for the summer, or just ideas for what we can do, especially in the summer. But I'd like to turn it over to our speakers for today. I really appreciate your presenting, and I'm going to let you, I don't want to cut into your time any more than I already have, and give time for discussion at the end too. So I'll turn it over to you. So thank you so much.
Thank you, Brett, for the introduction, and thank you all. It's a real honor and pleasure being here today. I apologize for the double profile, but I wasn't able to get one computer with the video and the audio, so I had to come up with this with this solution, and I hope everything works as expected. So please let me know if you can see the presentation. I hope so.
It looks good. You can put in
Looks good? Okay,
in
sounds great.
presentation mode if you want to put it in presentation
Yeah,
mode.
can you see?
It'll be even
Is
better.
that so? You can see that?
Yeah, but you can
Yeah,
make it
Okay.
full screen, right?
is it? Yeah,
It's not
um,
on screen on your...
I think click on that button. The presentation button. Yeah, the little.
because on my screen it is.
Oh, that's weird.
So
Okay.
that's weird. Let's see. Let's try this way.
Okay. And then there's
Does it work
there
better
you go.
this way?
That's great. That's
Okay,
perfect.
okay.
Thank you so
Got
much.
it.
Thank
So
you.
yeah, thanks again for this opportunity. I will do all the talks, but actually most of the work has been done by Professor Massimo Salvi, which is also today is joining, but he's traveling. So I'll do most of the talk, but he did most of the work. So this is just a little bit of disclosure. So this is just a brief summary of the talk. Of course, it's focused on steatosis and some of the metrics that we come up with and our algorithm for calculation. But I will also talk about what we are working right now and, of course, what we can make out of it. And so Steatosis, we all know what it is. It's the fat in the liver. It can't get any easier than that. But the issue with steatosis was how to calculate them and even how to define them. So we have this steatosis Tower of Babel, where almost not each institution, but several institutions have different ways of calling macrovesicular, microvesicular, large droplet, small droplet, or medium droplet. Luckily, this is a problem of the past, because nowadays we have the Banff recommendation that provide not only the terminology and the definition of what is relevant for the graft, of course, for the donor liver assessment and for the graft survival after transplantation, but it also provide an algorithmic approach, which is absolutely essential because it provides a standardized and regularized algorithm for calculating steatosis. But we all know that. And last meeting, we talked about, Dr. Burr talked about how AI can help us mostly in, those repetitive tasks, and which are maybe not so stimulating. And we believe that steatosis maybe is not that, the best, activity that we do maybe in our daily work. So we think about why we cannot develop an AI algorithm to calculate steatosis. And so we come up with our work. We collect about almost 300 donor liver biopsies, and those were evaluated by transplant pathologists and a convolutional neural network that we developed specifically for steatosis assessment. And we compare two different methods. So our pre-Banff method, that was the institutional method before the Banff recommendation were published, and then the Banff approach. So a little bit more in detail, the biopsy were FFPE, and I like to highlight that because this is maybe a little bit different than the experience of other centers, which are mostly working with a frozen section. But in the institution where we collected the biopsy, it was in use the microwave supported fast processing, which in about 2-3 hours provide you with an FFPE, so a formalin fixed paraffin embed biopsy. And of course, there was slide image. And before performing the actual algorithm analysis, Massimo, Salvi, and I are quite enthusiastic about the pre-processing phase. So actually work on the image before performing the actual analysis in terms of metrics and segmentation, and specifically about state normalization. And we use a GAN-based approach, so that all image that may have a variability in terms of staining and intensity of hematoxylin and eosin were actually normalized. And this is very helpful because it allows us to have data that we can actually consider reliable and robust. After that, we actually have the segmentation steps, and different from other papers and other studies, we decided to apply a 3-step segmentation process. So not only the steatosis versus the background, but we also decided to develop a steatosis boundary and edge detection. And this was actually pretty helpful because it allows us to distinguish much better steatosis from other aspects of the tissue biopsy that can mimic the steatosis, such as a vessel or bile ducts or even artifacts on the tissue or the sinusoids as well. And for the steatosis definition, we actually use only dimensional criteria. So in terms of how big the droplet actually was. Then we developed after the state normalization and the segmentation, we actually applied the algorithm. And it's an algorithm that is based entirely on the Banff recommendation, at least for the part, of course, related to the Banff recommendation, which means that it has a part where we calculated the low power steatosis. So it goes through all over the biopsy, even the tissue folds that you can see here, that at least tell us that the biopsy is real and it's not a fake one. And it evaluates the low power steatosis and provide a percentage. After that, we have a scrolling window that goes through the areas where the steatosis was identified at low power and perform first the steatosis segmentation and then a nuclei segmentation. And the nuclear segmentation that we performed was actually developed so that it identified the hepatocyte nuclei only, based both on dimension and on nuclei elongation. So how the nuclei was actually round versus different shape. And this allows us to identify hepatocytes and differentiate them from Kupffer cell, endothelial cell, and anything that is not hepatocyte. As you can see in the very last part of the image, the nuclei are the green one, the macrovesicular steatosis is the orange one. And maybe it's not very, some hepatocellular nuclei are missing in the image if you look at that, but we prefer being specific over the nuclei identification and be sure that what we identify as nuclei were actually hepatocyte. And nowadays we develop an improved system for nuclear segmentation that actually improve also the ability to detect all of the hepatocyte nuclei. And after identify the high power score, the algorithm that we develop actually provide you each type of percentage of fat calculation. So the low power steatosis, the high power steatosis, and the final score. And we believe that this is actually very useful, especially if we think in terms of clinical implementation of any type of AI, because this way, if by any chance the percentage, the final score that the algorithm provides us is somehow different from what we were expecting, we are able to go back and look where actually the issue is coming from. If maybe the low power score was too high or too low, or the high power score was somehow calculated in an area that was not the best one. And this is a visual representation of how the algorithm provide actually the stratification, the differentiation in small droplet fat and large droplet fat. And of course, the large droplet fat is highlighted in orange, the small droplet fat in light blue. And I believe this is also helpful, again, for the clinical implementation, because it allows us to see for the pathologists to check where actually the calculation by the algorithm has been literally made. So which type of droplet fat were considered either large or small droplet. These are actually the result of the overall study. So what I talked was about the algorithm that we developed with the Banff mess. So an algorithm that was instead developed based on a pre-Banff method, which was actually considered steatosis as a whole. So macrovesicular, microvesicular, large droplet, small droplet, almost everything was put together inside a score of steatosis. And we were interested to see how the pathologists and the AI were agree actually on the steatosis percentage using the pre-Banff method and the Banff method. And what you can see here at the top is a table that shows you the mean difference. And this refers to the mean difference of scoring of percentage between the AI and the pathologist. So using the pre-Banff method, there was about 25% of steatosis or percentage of steatosis of difference between the pathologist and the AI. With the Banff method, this difference dropped down to 0.49 or 0.4. Whereas the ICC, it's some metrics to define the agreement between different evaluators. And as almost all type of agreement metrics, 0 means no agreement, 1 perfect agreement. As you can see, apart from the mean percentage and the mean difference, even the ICC for the Banff method is 0.9, and for the pre-Banff method is 0.1. On the lower part of the image, you can see actually the waterfall graph. These are mostly seen in the clinical trials to see the effect of drugs, but I thought they were actually helpful to visualize the difference. And here there are two messages that I believe are quite relevant. The first one is, again, the difference of percentage between the AI and the pathologist. So what you see as a positive value, so from 0 to 90, is every time the pathologist provides a score that was actually higher than the AI. And the negative values instead are when the AI provide a higher steatosis score compared to the pathologist. The graph on the left side is for the pre-Banff method, and the graph on the right side is for the Banff method. And the two key messages, of course, that first, the either both the maximum difference between the pathologist and the AI and the average is much higher with the pre-Banff method compared to the Banff. But also another thing that I think is relevant is that if you look at the x-axis, the biopsy where the difference is higher in both in one system over the other is actually different. So that means that it's not the biopsy per se that was maybe difficult to evaluate, but rather there were some different metrics or different issues that come up with the two different scoring systems. Regardless, the main message is that the Banff method, the comparison of pathologist assessment and AI assessment with the Banff method provide much more reliable and actually narrow percentage than the pre-Banff method. Following our study, our algorithm, there were other centers that also published their AI steatosis assessment tool. And this is absolutely amazing because it allows us to actually identify some key aspects that are common between different AI algorithms. Because even in the work of Ji Hao and colleagues, or partially also in the Kikuchi and colleagues' work, even if the Kikuchi and colleagues is not AI based, but the message is always the same, meaning that the Banff recommendation actually improve the agreement between evaluators. And there is also another message that comes up both from our works and from these other papers that were published, and is that the percentage that come up with the Banff recommendation are generally lower than the percentage that you can obtain with any other type of scoring system. And this is irrelevant because it's telling us that maybe we are discarding more organs than we actually should, because the percentage are higher with any other Banff, any other system that is not the Banff recommendation. So this was actually a little bit of the introduction of the paper that we already published, which is already free. It was already 3 years ago. And since then, we worked on additional on improvement over the algorithm. And this is a little bit of what were the main areas that we focused on. And the first one is, of course, about the frozen section. As I mentioned initially, this algorithm was developed on FFPE section, but in the US or in other countries as well, the frozen section are actually maybe more common. And so thanks to the Banff Steatosis Fatty Liver Working Group and Desiree Neal and Drew Lesniak, we were able to work on a series of frozen section slides, the leads, training, and evaluation sets. And we were interested actually first to look whether the algorithm, as it was developed for the FFP section, was also able to quantify steatosis appropriately on the frozen section. And then we also, starting from that, we also update the algorithm and we develop to tailor for the frozen section assessment. And part of the data were already presented at the Banff meeting in Paris last year, but some are updated. So I'm going to show you what actually changed. And so this is the before, meaning that this is how our algorithm that was developed on FFPE performed on frozen section. And as you can see, this is a case with a low percentage of macrovesicular steatosis. And both the median value of the evaluators, of the pathologist, and our algorithm are quite similar, 2.5 for the pathologist, 1.4 for the algorithm. If we look at cases with maybe a little bit more of large droplet steatosis, again, the pathologist median is about 30%, and our algorithm is about 26.6, so again, quite close. But if we look at the segmentation, we can see, as the yellow arrow in the right panel is indicating you, there are some segmentation that were actually not very specific and not appropriate for the large droplet segmentation. So we come up with an improvement in terms of mostly about the staining, because what changed between the FFP and the frozen section was how actually the white spot were whitish and the pink spot and the pink parenchyma were pinkish. So with the frozen section, it's much lighter, the overall parenchyma, but the fat droplet can be not as white as with the FFP. And we improved that. We improved the segmentation on the frozen section, and a little bit also the nuclear detection. And these are actually the results. So on the left side, you see the metrics of the algorithm before any type of development for the frozen section. So on the left side is the algorithm based on the FFP training set. Whereas on the right side, the after is the algorithm following the modification for the frozen section. And the training set, evaluation set, and in the next slide, the lead set are just referring to the different frozen section set that we use for the analysis. And as you can see, there are the cases from 1 to 15 for the training set and 1 to 26 for the evaluation set. With the FFP, let's call it the way, the FFP or the B4 algorithm, there are some cases where there is quite the difference between the pathologist evaluation and the algorithm. And for our reference, we consider significant when it's more than 10%, because it may change actually the classification, the use of the organ. And it's relevant because, as you can see, there are some cases where they go over the 10%, and in some cases, like the case number 7 in the evaluation set, this is about 50% difference in steatosis percentage, which is a lot. After the changes and the development and improvement, we can see that there are still some cases where the difference is relevant, but overall the difference are much lower. And this is also evident with the lead set, where the case 8 is still actually relevant, but with the FFP use, it's over 40%, whereas after the improvement is about 25-26%. And this analysis was useful not as much to tell that we make the algorithm better, which was not the goal, but what is relevant is to see that despite changing the algorithm, make it better for one solution or the other, there are still some cases that are challenging, that are here shown by the red arrows, like the case number 15 of the training set, and the number 7 and 19 of the evaluation set, and the number 8, 16, and 18 of the lead set. This is something that actually was evident even with the pathologist assessment alone. So there are some cases that even if we are not considered the AI versus human or just within the human, provides some issues in the evaluation. And the use of the AI actually help us identify those cases and maybe identify the cause of this issue. And when we look at these samples, looking for these causes of what can cause these discrepancies in evaluation of the steatosis, we mostly identify 3 main common denominator, which are the fragmentation of the tissue, the droplets dimension, and the frozen artifacts. And so these were the 3 areas where we worked to try to develop, to identify some solution for the AI, but in general for the steatosis assessment. For the fragmentation, we already had some hints. That's because when we first submit our paper, one of the reviewer actually asked us for the tissue quality requirements, meaning the adequacy of the biopsy. And of course, the biopsy were adequate for the study. But when we additionally report that the adequacy criteria, we were actually thinking critically about it. And we said, okay, generally the liver biopsy adequacy criteria are the number of portal tracts or the biopsy lengths. But are we really sure that these are appropriate for the steatosis, which is a lobular event? So the portal tracts are somehow useful because it's a surrogate of the dimension of biopsy for sure, but maybe not the best type of criteria, and neither is the length. So we come up with thinking about maybe it's not the length for the number of portal tracts, but maybe it's the fragmentation. Now, what you can see here on the left side, it's very peculiar case. I believe nobody has ever seen something like that in their practice, maybe, but it was actually a real case of a donor liver evaluation biopsy that come up in our institution. And on the right side, maybe is the more typical liver biopsy that you have to evaluate for donor eligibility for steatosis. And our idea was that as human beings, we are more able, let's say, to evaluate something when we have the whole picture rather than identify objects in different fragments. Whereas if you think as a CNN of an AI algorithm, maybe if the tissue is fragmented or if the tissue is just one biopsy, I'm not sure how much this actually is relevant because the calculation is made based on the tissue alone. So there may be our hypothesis was that there may be some difference for the human, but not for the AI. So in order to test that, we collect some biopsy. Again, this time different biopsy from those of the paper. And our aim was to, again, evaluate whether this fragmentation or other metrics were actually did actually have an impact on the steatosis assessment, and whether the use of the Banff recommendation actually mitigates these effects. And our idea was that they may actually do that just because the Banff recommendation per se provide you an algorithmic approach for the steatosis assessment. So basically you have to do the maths and do the calculation. And so somehow we thought that you have to focus a little bit more on the steatosis assessment rather than overall assessment of the tissue. So we come up with 50 biopsy just as a pilot study. And we collected only the biopsy where actually there was some steatosis. The reason was that if the biopsy has no steatosis and it's 0%, in our idea was that doesn't really matter whether it's fragmented or not, because you can tell immediately that there is no steatosis and this is a 0, and that's it. So we collected biopsy that have either a pre-Banff score or a Banff score that was higher than 0. And we evaluated some traditional, let's call it that way, quality metrics like the number of portal tracts and the total length, and some more explorative like the fragmentation, the total area, the density of portal tracts, so the number of portal tracts per tissue area, the weighted fragment length, so the total length of the tissue per the fragmentation of the tissue, and similar with the weighted fragment area. And then the replay L function, which is actually a matrix from the geospatial statistic, which is used to identify whether on a surface, on an area, some items are dispersed, clustered, or randomly located within the area. And if you think of the tissue fragment as items on a spatial area, we can maybe calculate if they are dispersed, randomly located, or clustered. And to see let's say the parameters that we use as reference to evaluate whether this matrix has an impact or not, were the discordance rate. So again, how the mean difference of percentage between the steatosis assessment of the pathologist and the steatosis assessment of the AI. And again, the ICC score as a measure of agreement. And okay. So these were the overall metrics of the 50 biopsy. So the number of portal tracts, maybe they were not optimal, the lengths a little bit more. And the median fragments were about 3, ranging from 2 to 7. The total area, you can see the data here. And the replay L function, it's just a focus here. It's not on the whole series, just on 40 biopsy. This is because to have fragment cluster or not, you need to have at least 2 fragments. So that's why the total sample size was a little bit lower. And what was interesting is that when we correlate these quality metrics with the pre-Banff method, we actually see that indeed the higher the fragmentation of the tissue, the higher the discrepancy between the pathologist evaluation and the AI evaluation. And similar was for the weighted fragment length and the weighted fragment area, but not for the portal tract number or the total length of the biopsy. And here you can see the graph which correlate the steatosis percentage and the total fragments on the left side. So the higher the number of fragments, the higher the discordance between pathologist and AI. the weighted fragment length and the weighted fragment area, which actually works the other way around. So the higher the weight fragment length, the better the quality of the tissue. So here you can see that whenever the weight fragment length was lower, there was more discordance, and similar for the weight fragments area. And even more interesting, when we were looking at the very same biopsy, but with the Banff score and not with the pre-Banff score, actually there were almost no impact of the fragmentation or the tissue quality on the discordance between evaluators. And so our idea, which is a little bit of maybe more of an hypothesis rather than an idea per se, is first that maybe for the steatosis, we may look at different metrics rather than the portal tracks or the total length, and maybe some like the function. And the other aspect was actually that maybe this is not much relevant at all, because nowadays with the Banff recommendation, this may actually mitigate the impact of tissue fragmentation. And so this may prevent some type of biopsy bias from that perspective. So if it's not fragmentation, what can be the issue with the discrepancy between evaluators and AI? Well, maybe it's the dimension of the droplet. This is again one of the first slides that I show you, where the Banff recommendation tell us that what matters is the large droplet within the macrovesicular steatosis. But if we look at the image on the right side, and specifically on the yellow box, we have some droplet fat, which, as you can see, the AI differentiate between the large droplet fat in orange and the small droplet fat in light blue, but they're very close in terms of dimension. So if we focus on this one, maybe you can say, okay, this is actually larger, this is smaller. As human beings, we can do that, but it's obviously challenging. It's even more challenging when rather than three of this couple, we have 6, 8, 10, or we have the whole tissue where we have to make this difference. So what we are actually working on is trying to develop these adaptive dimensional thresholds, which works like actually a very basic tool where you can actually modify the cutoff, the dimensional threshold that the AI use to identify large droplet versus small droplet, and see how the percentage of steatosis change based on how you change the dimensional threshold. And we believe that this may actually be one of the major causes of the discrepancy between AI and the human evaluation, pathologist evaluation, just because what we consider the large droplet may change based on the whichever we are looking on and our personal experience. Of course, in addition to identify causes, all of this is developed mostly to identify something that is useful for the patient and for the transplant. And so the ultimate goal is to maybe change what are the generally accepted threshold for steatosis assessment for the 30% and 6%, or 43 and 66, depending on the studies. And this is a very preliminary analysis that has been done by the surgeon, the surgical unit at the University of Turin. And as you can see, actually the numbers are very skewed towards the macrovesicular steatosis, the large droplet, 205 in that category. But it's telling us that maybe we should change the threshold that we are actually using for the donor allocation, for the donor allograft liver allocation. And this is something that, again, as I mentioned before, is coming up both from our study, but also from other studies as well, meaning that the steatosis assessment with the Banff recommendation may provide percentages that are actually lower than we were used to have in the literature and in our studies. So as a final recap, I believe that these algorithms are pretty useful because they allow us to have unbiased and reproducible scoring system, and the ability to have them based on the Banff criteria, and specifically having all the score differentiated, so the 3-step, low power, high power, and final score. This may be additionally helpful for the clinical implementation, but also for identifying critical areas and issues to further development. And another aspect which is quite relevant is the reproducibility of these tools and how they actually provide the calculation every time in the very same way, so in a standardized way. And this further supports the use of the Banff recommendation, especially compared to the pre-Banff method. And in general, these are the overall goal, as Drew Lesniak said, and we all agree about that, is not identifying one tool which is the best. That's not the goal of this area of this field of analysis, but it's actually using this tool to identify what are the critical areas where we have to improve. That can be the dimension of the large droplet, can be the tissue artifacts, whatever it is. These AI tools allow us to identify what can be these causes and how we can work on them to develop further the field. And in conclusion, this is a lot of data, maybe a little bit summarized, but there were a lot of people that I have to thank for all this data that I present, starting with the University of Pittsburgh, Dr. Dimitris, Lesniak, Dr. Minavidi, and their RHS team and the unit there in general. Of course, the fatty liver working group. As I mentioned, some of these slides were part of the presentation that we did at the Banff meeting in September. And the Turin group, in particular the Polytechnic of Turin with Massimo Salvi, that, as I mentioned, did all the AI works and the development of the neural networks, and the University of Genoa, where we're actually working right now. And I'm more than happy to take any further question or comments that you are curious about.
Hey, Alessandro.
Hello,
Nice to
Dr.
see you.
Mandawa.
Nice to hear you. Nice talk.
Thank you. Thank you so much.
I had a question. So, do you have
Sure.
the data which actually tells you the diameter of all the droplets? So that would be a separate effort if you wanted to calculate, in addition to the percentage, also the area of each little damn droplet in the biopsy. You know?
Yeah. So the way we developed initially was to set up a definite cutoff. If I don't mistake, it was about 200 micrometers or something like that square. But what do I say that we are developing the adaptational tool was exactly that. So instead of having one cutoff, one specific number that differentiate between large and small, rather having the option to have a continuous range where you can actually see the area that you are considering and then have the visual representation of what the algorithm has been considered as large droplet or small droplet. So maybe not the exact number.
Sorry, please continue. Please continue. Yep.
Yeah. No, maybe not the exact number of each droplet. There may be a lot of calculation power, but at least have the visualization of what has been considered as large droplet and small droplet based on how you tweak the cutoff.
So one other area I think you could help solve is the focal distribution of the fat. You see, that's another thing which contributes to variability. So I would suggest you work with some mathematicians, which also gives you an index of the variability. And then you incorporate that into the percentage and come up with the probability score, which also captures the uncertainty because of the focality. You know, think of how you would do it. It will advance the field.
Yeah. That's actually absolutely interesting and helpful. And the good thing is actually, as I was showing you for the fragments, you can actually apply that also for the steatosis localization, as you mentioned, because you can put a centroid. Once you have the whole slide image, actually you have the coordinates, so the X and Y coordinates. So you can locate the centroid of each droplet and then make the, as you mentioned, how they are dispersed or clustered or randomly distributed among the lobule, if that's what you mentioned, if I get it correctly. But that's absolutely.
Do you have a database like UNOS in Italy? You know, that's where you should apply the data and get large outcome studies done.
Yes. Unfortunately, I would say it's not as much organized, if I can say that, because some centers do not perform the biopsy and just rely on the surgeon perspective. Other centers send the biopsy elsewhere and then get the data, but they don't share in the database. But yeah, at least with the data that we have available, that would be absolutely interesting to evaluate.
Thank you and congratulations. Very nice work.
Thank you. Thank you so much, Dr. Mandawa.
Yeah, that was a really great presentation. I admire your work so much, and this is something I worked on with some collaborators, and you did it much better than at a higher level than we were able to do. One thing we did try to do was like get some sort of like gold standard, and we collaborated with some like radiologists who have MRI measurement of fat. And I was wondering if there might be in the future, if you could see the utility of that, maybe like having radiology surrogate or also even maybe a tissue. I don't know. It would have to be a special study, but like a tissue, like um, molecular method to measure the fat in the liver, because I know oil red O tends to over exaggerate it, but there's
Yeah,
got to be
yeah.
some gold standard. And have you thought about that?
Yeah, that's absolutely an amazing area. Actually, for the outside the transplant domain with the methyl, methyl, they're actually going straight forward toward that direction with MRI, with FibroScan. Almost, I'm not saying the biopsy, they're not considered that any longer, but we are getting there. And yeah, that would be absolutely, we cannot, we have to be objective actually, and that's actually the future. So once you have the MRI and you have a good correlation with the tissue and you're able to do that, that's absolutely provide more information. Actually, nowadays, so yeah, nowadays they're not as good. Maybe not for the fat per se, but for other metrics that are relevant for the transplant, like inflammation, necrosis in general, which is something that maybe in addition to the other domain, the muscle and mesh, whatever, here are more critical because they also guide the decision over the eligibility of the organ. But for the world of the steatosis, that for sure. And what you mentioned, having something more reliable, that would be the goal. And I believe that maybe once we have developed a little bit more of this, I will not say gold standard because it's as I show you, there's always room for improvement. So it's tough to identify a gold standard for that for the AI, but definitely we can get closer to that and maybe do the correlation. That would be awesome, of course. But as I said during the meeting, the goal is not to have one tool that works for all. I believe that the example of the FFP and the frozen section actually is a good example into that. And even with the stain normalization, we use that, but some other center may not. So there's room, there's heterogeneity in the sets that we evaluate. So the goal is not to have a perfect tool, but to use the tool to identify where we can improve. So make even the idea of Drew Lesniak and the fatty liver group was to sort of make a database where we can maybe test different AI algorithms, see what criticisms come up with the different algorithms, and then identify those areas for overall improvement. If that makes sense.
Oh, that's great. I really admire what you're doing. Does anyone else have any questions?
Yeah, Hassani, great job. Yeah, I'm from Sana. I have a quick question because
Sure.
I don't know anything about the liver pathology. My question is, did your algorithms identify like a region interest, which means maybe some region have enriched like a droplet, other region has a less droplet? I don't know. Is any like a point to identify some like regions enriched with droplet compared to rest of
to the rest? Well, we are working on that, I would say. That was not the initial goal, to be honest with you, because we were working with the wall slide image and we were interested in make something very similar to the Banff algorithm approach, which consider the whole tissue and not maybe as much distribution, if that makes sense. But we're also, as we said before, maybe that's definitely something that we can implement further and say, okay, this area is, there's a more concentration of fat. It's more homogeneously distributed rather than in different areas. And what may be interesting to see is also whether this has a clinical impact or not. I don't know if maybe there's always the data about that that I don't know, but the idea was that correlated that with maybe the inflammatory infiltrates may also provide some additional information. with
Yeah,
like the steatosis surrounding the large droplet, or yeah.
that's so similar to what we're doing in kidney pathology, identify like a region with like a fibrosis compared to other region. Yeah. Okay, great.
I think it's akin to what Parmjit asked earlier, Alessandro.
Exactly.
Looking at distribution, but I think you're going to need a true gold standard again there because you have to deal with sampling bias, and so you need some way to objectively, determine does it actually impact, and then look at the outcome. So I think it'd be interesting to start pulling it,
Yep.
and you could probably even do it post. You don't necessarily even have to do it as part of the classification algorithm. So
yeah, it may also go back to the MRI aspect. You mean you have the radiology that maybe assess the whole liver, then you have the biopsy, and if you are able to specifically identify where the biopsy have been taken and maybe correlate with that, I don't know. There's definitely a lot that can be interesting, at least to look at. But as you said, yeah, of course, defining the gold standard will be the first step for that.
Also, next question. So are you planning to do like integrate your pathology data with special transcriptomics? Is there any like a integrate like pathology with like transcriptomic data? Biological analysis?
We don't have the resources to do that with the sample that we have, to be honest with you, but it would be absolutely interesting, of course.
Yeah.
So I have one more suggestion, Alessandro. As you know, the thickness of the frozen section can dramatically affect the apparent size of the droplet.
Yep.
So here's another tool which you can use to really quantify that phenomenon. You should do it.
Yeah, yep, absolutely. That's also a very good hint. Yep. I'll immediately take note of that.
All right. I took notes of what you said,
Any other questions?
I'm not sure if Massimo want to add something maybe on the more technical part, since he actually did a lot of the work.
I completely agree with the question that were made. We are working on, since there isn't a score that fit all the assessment, we are working on providing additional output for this algorithm. In particular, we are working on the side of uncertainty quantification, because we don't believe that the algorithm should provide only one score, but also assess the uncertainty associated to that score. As Alessandro said, sometimes there are steatosis that are very similar in size, while the algorithm apply let's say a hard threshold. So we are also trying to quantify how close the sides of steatosis are in order to provide a more objective measure of the output. Indeed, we are working on this topic, and we are trying to correlate the pathologist agreement on a specific slide with this uncertainty measure. We don't have the final results yet, but by slightly changing the threshold applied to identify macrosteatosis, we are able to quantify and sort of predict the agreement or disagreement of pathologists that analyze the same slide. Because if the HP score change a lot, if we move a little the threshold for identify a steatosis as macro or not, it means that we expect higher inter-observer variability. Otherwise, if we change the threshold but the score remains pretty the same, this would be a very certain prediction, and we expect a very high agreement between pathologists. So this is a very interesting procedure that we are applying on the AI algorithm to enrich the output.
Awesome. Yeah. Well, that's great. So how much human annotation did you have to do? Was it, were you able to do just a limited amount and then it was able to learn from that, or did it require a whole lot?
Yeah, we fully annotated more or less 100 tiles because the steatosis segmentation is a relatively easy task compared to cancer grading and detection, and the algorithm does not need a huge amount of annotation to distinguish between steatosis and tissue fragments, sinusoids. So indeed, the same network was applied also for frozen section without the need of additional manual annotation. Thanks to the state normalization, we were able to, let's say, mimic formalin fixed slides from a frozen section. So, and these make the task for the network easier. Obviously, there are some cases where the network fails, as Alessandro showed in the presentation, especially when there is a huge amount of touching steatosis. Most of the time, the network is not able to distinguish the correct number of steatosis if they are merging, if there is, for example, a fragments tissue fold. This is something that we are working on, and we plan to apply a sort of artifact segmentation, or more or less quality control that is able to guide the segmentation performed by the network.
So I have a last question. So how do you distinguish like a big droplets with like a big hole in the tissue, like artificial holes? Is a distinguished by the annotation, many annotation, or your algorithm can distinguish between the big droplets and the big holes in the tissue?
So for the frozen section, like there was part of the aspect that we are dealing with for the artifacts induced by of course, by the highs, by the water becoming acid and rupturing the tissue. Somehow with the segmentation, as I mentioned initially, we use a 3-step segmentation that, in addition to the steatosis and the background, also use the boundary, and that allow that whenever it's not as rounded as expected, it at least flag that there is something that it's not working appropriately. On the other hand, though, if you remember, maybe I can show it again very quickly, but when there was a yellow arrow, remember the macrovesicular steatosis that I said here, there's room for improvement, because that macrovesicular steatosis, that large droplet was rounded for 90% of its perimeter, and then has a little bit of a prolongation, let's say, which in that case was absolutely the fat, but by the algorithm was recognized as something that is not within the shape of the droplet and was discarded. So I would say that for the purpose of identifying fat droplet, which are mostly rounded, maybe it would be better to preserve the round shape. But of course, we can work on that as well for sure.
Yes.
But at least that was the metrics behind that.
Yeah, your product work very well based on the slides you show.
Yeah.
Yeah. Right.
Definitely.
Yeah.
Well, this is your awesome work. I really admire all you've done. Are there any? I could go on for a while, but I don't want to keep everyone. I might ask you, because I might revisit this in the future some more. But does anyone else have any last questions? Well, thank you again. I really admire your work, and like I said, I may connect later because
yeah, sure.
Yeah,
that would be awesome. Thanks to all of you for this amazing meeting. They're absolutely very nice.
Oh, great. Well, this one was I really enjoyed this presentation, and y'all take care, and we'll see y'all in 2 weeks then. Thank you so much.
Thank you.
Thank
Good.
you. Bye.
Thank you. Bye-bye.